Any more questions?
Okay, we shall proceed to the next presentation.
Thanks, Paul.
Thank you, Ms. G. Following that is a 27-month retrospective study regarding the effectiveness of ST elevation myocardial infarction management in UKMMC. This study is from the Department of Medicine. Let us welcome Ms. Ho Ping Ling from Group 20.
A very good morning to the fellow judges, honorable judges, professors, lecturers, doctors, and fellow colleagues. I am Ho Ping Ling from Group 20, will present on management and outcome of ST segment elevation myocardial infarction, STEMI, in UKMMC. STEMI is defined as myocardial infarction due to total occlusion of the coronary artery. Based on WHO criteria, it can be diagnosed by clinical history, ECG changes, and evidence of elevated serum cardiac markers. In year 2006, acute coronary syndrome has an incidence of 7.1 per 100,000 Malaysian population. At the same year, National Cardiovascular Disease Database 2006 had reported that STEMI composed the highest percentage among all acute coronary syndrome patients studied. Previous study has also showed that mortality rate of acute myocardial infarction could be as high as 20%, and early reperfusion therapy could reduce the morbidity and mortality. Our objectives of study are to determine the social demographic profiles of STEMI patients in UKMMC, to determine the adherence to current treatment guidelines on management of STEMI, and to conduct an observational comparison between UKMMC and NCVD 2006 data. NCVD is a National Cardiovascular Disease Database which includes incidence, clinical management, and outcome of 11 hospitals across our country, including IJN and UKMMC. Thus, it reflects the demography, clinical management, and outcome of our own nation. That's why we choose NCVD to compare with. Our study is a retrospective study from January 2007 to March 2009. There is a total number of 264 patients who were enrolled based on inclusion criteria of age 18 and above, diagnosed with STEMI based on WHO criteria as we mentioned before. Those who did not fulfill WHO criteria of STEMI were excluded. The source of NCVD data were from NCVD ACS Registry Report 2006, and our study had obtained ethical approval. To recruit our patients, we obtained the patients list from Cardiac Care Unit Admission Logbook. Then we request for medical records from record department. We fill in the inpatient and 30-day status data of patient into a data collection sheet. For patients where 30-day data were not available in medical record, we'll call up the patient and ask specific questions. These were the results of our studies. As we could see here, our patients were normally distributed at the mean age of 56, similar to that in NCVD. Patients from both settings were mainly from age group of 50 to 60. Most of patients were male, similar to that in NCVD. And most of our patients were Chinese. But however, in NCVD, most of them were Malay. Of immediate management, we could see clearly from this pie chart that up to 80% of our patients were reperfused via thrombolysis. Of those who were not thrombolized, they either had proceed directly to primary percutaneous coronary intervention, or they were either contraindicated for both, or they had missed thrombolysis. As we mentioned before, early reperfusion therapy could reduce the mortality and morbidity rate. Thus, we had looked into the time taken for initiation of therapy upon presentation of patients to our emergency department, which is the door-to-needle time. As we could clearly see here, only about 40% of patients were given early treatment within the recommended time, which is 30 minutes. The mean door-to-needle time was 61.74 minutes, twice the recommended time. These were the pharmacological agents used in STEMI patients. as we could see here, more than 80% of patients were given aspirin, ADP antagonist, beta blocker, and statin. This signifies that UKMMC has a good clinical practice according to clinical practice guidelines. As we compare observationally with NCVD, the percentage of use of pharmacological agents was similar, except that we had higher use of ADP antagonists, unfractionated heparin, and beta blocker. We also look into outcome of STEMI patients in terms of overall mortality rate and mortality rate by immediate management given. This shows the in-hospital mortality rate according to immediate management. As we had expected, patients who were not reperfused has a high mortality rate at 18.6%, increased up to 20.9% at 30 days. Meanwhile, patients who were reperfused either by thrombolysis or via primary percutaneous coronary intervention has equal percentage of mortality rate at 7.7%. There were no deaths after discharge. In-hospital and 30-day mortality rate were at 9.5% and 9.9% respectively. When we compare observationally with NCVD, they were rather similar. From this study, we conclude that UKMMC has a good clinical practice and had adhered to clinical practice guidelines as evidenced by the immediate management given and the pharmacological treatment. However, the goal of time for door to needle was not achieved yet. We think that it could be due to late referral and the administrative procedures involved. On the other hand, through observational comparison with NCVD, we noted that our patients' demographic profiles, management, and outcome in UKMMC were comparable to all the 11 hospitals involved in NCVD. This is evidenced by similarities in mean age, age group, gender, percentage of thrombolysis, and mortality rate. Nevertheless, there were certain differences that we had observed. In UKMC, we have more Chinese, while in NCVD, there are more Malays. The percentage of use of pharmacological agents were more in UKMMC compared to NCVD, and door-to-needle time was shorter in UKMMC. We think that management in UKMMC can still be further improved to lower the mortality rate and to provide a better acute coronary care service. This could be achieved by improving the door-to-needle time, while we can educate the public and allied healthcare personnel about the importance of recognizing and diagnosing STEMI early, and about the importance of early reperfusion therapy in these patients. We would like to acknowledge the following personnel who direct and indirectly helped us in this study. With that, I thank you.
Two questions. First, how do you explain the differences between your study and the NCVD? Number two, what do you recognize as limitations of your study?
Can you please open the slide? Hold on. Okay, first of all, the differences in terms of ethnic group, we think that UKMC has more Chinese because in Cheras there is more Chinese population in this area. The percentage of use of pharmacological agents, as we can see here, okay, we have higher use of ADP antagonists, unfractionated heparin, and beta blocker, as our study was includes 2007 to 2009, whereas this NCVD, their report was released at 2006. ADP antagonist and beta blocker was included into CPG for STEMI patients of 2007, which we are referring to. Besides, for unfractionated heparin, because in our settings, we have more availability of unfractionated heparin, and towards the year 2008 and 2009, we use more of recombinant tissue plasminogen activator, which it is a must to give unfractionated heparin after we thrombolize them. Besides, NCVD, we noted that NCVD actually use more low molecular weight heparin. That's why their percentage are slightly lower than ours. Okay. Any questions?
Okay, if you don't get the data and information from the record office, what sort of question you ask these patients, especially the names of the drugs?
Okay. Basically, we get most of the data from our patients' data from medical record, and then for those patients where only the 30 days data missing, for example, we got all the demographic profiles, the management, pharmacological agents, we got it. For only that, when they are discharged, we don't have they didn't follow up at our clinic. That's what those are the patients that we call up for the questions, and we ask whether these patients are still around, are they living healthy, and we ask specifically if any patients who had passed away, then we will take into account as into mortality. Does that answer your question?
Perhaps one more question?
Thank you.
Thank you, Ms. Ho. Our next presenter, Ms. Norokia Mohamad, representing Group 29 from the Department of Nursing, has conducted a cross-sectional study to assess the lung functions during an acute attack and the quality of life amongst asthmatic patients in UKMMC. So without waiting any longer, we shall let Ms. Norokia begin her presentation.
Good morning and assalamualaikum to the honorable judges, professors, respected lecturers, and fellow colleagues. Today, I'm the representative from Group 29 who would like to present our study entitled Lung Function Assessment During Acute Attack and Overall Quality of Life Amongst Asthmatic Patients in University Kebangsaan Malaysia Medical Centre. We were supervised by Madam Ho Seung from Nursing Department. I want to draw your attention that asthma is a serious lung disease affecting 150 million people worldwide. Even in Malaysia, the incidence is reported to be 4.5%. And the third National Health and Mobility Survey reported that Indian is the highest percentage, followed by Malay, others, and Chinese. While quality of life can be defined as the degree to which a person enjoys life, and literature has proved that those who suffered with asthma will be definitely handicapped by physical, emotional, and social activities. So our main objective is to assess lung function assessment during acute attack and quality of life among asthmatic patients in UKMMC. And we further divided our objective into 3 specific objectives, in which the first one, we want to assess the lung function before and after nebulizer treatment. And second, we want to determine the association between demographic data with quality of life. And lastly, we want to identify, is there any relationship between frequency of hospitalization due to asthma in a year with quality of life? This study consists of 4 parts, in which part A, we assess the socio-demographic data, part B, we identify relevant clinical history, part C is regarding asthma quality of life questionnaire, AQLQ, and part D, we assess the lung function. The study was done at the Yellow Zone of Accident and Emergency Unit from November 2009 until March 2010. This is a cross-sectional study using convenience sampling, and Cochrane 1963 was used to calculate sample size, and there are 95 respondents recruited in this study. We used 32 items of asthma quality of life questionnaires, which was validated, and there are 4 domains analyzed under this questionnaire, and we use scoring scale of 1 to 7, in which 1 indicates severe impairment, 4 indicate moderate impairment, and 7 indicates mild impairment in quality of life. And the questionnaire was self-directed by respondents, and we used SPSS version 16 to analyze data. And lastly, the study had been approved by UKM Research Ethics. There are several criteria we use to choose the patient as our respondent, in which they must be more than 18 years old, admitted to the A&E due to asthmatic attack, and prior consent must be taken, and they must understand English and or Malay language. But we will exclude them when they have mental problems, communication problems, or unable to complete questionnaire, or when they presented with serious condition. This flowchart showing how we conduct the study. The first one is we used to assess the lung function using peak flow meter to assess peak expiratory flow rates and using pulse oximetry to assess the saturation of peripheral oxygen. Then respondent will receive nebulizer, and then after that we will remeasure again the PEFR and SpO2, and lastly, while the respondent at rest, we will give questionnaires for them to be answered. Here we come to the result part. Let us have a quick glance on the descriptive analysis of socio-demographic profile. To make it easier, those in circle is the highest percentage. So we found that majority of our respondents were female, aged between 40 to 61, Malay, and married. And most of them have children between 3 to 4 and live with spouse and children. Majority of them achieve secondary educational level and mostly retired and not working. And half of our respondents earn less than 1,000 ringgit per month, and most of them were non-smoker. And lastly, we found that there are 72.6% of our respondents have been hospitalized less than 3 times. This shows the descriptive score of asthma quality of life, and as you can see, the mean total score is 3.76, indicates that our respondents possess moderate quality of life, and the highest score belong to environmental stimuli and the least to emotional function. And in this study also, we proved that there is significant difference between the oxygen saturation before and after nebulizer administration, as been shown in this table. And the same goes with the PEFR, which also has significant difference before and after nebulizer administration. However, among the 10 socio-demographic profiles we assess, there is no association between age, gender, race, marital status, number of children, living with whom, smoker status, number of cigarettes, educational level, and occupation with quality of life. However, there is only one significant socio-demographic profile, which is income, which is associated with quality of life. So, we further narrow down to see which domains in the income is actually affected by quality of life. And as you can see, only activity limitations and environmental stimuli is associated with quality of life. And how it is conducted? So, as you can see, the higher the income, the better quality of life. And by the way, there is no association between frequency of hospitalization with quality of life. So I would like to discuss that our respondents in this study possess moderate quality of life, and environmental stimuli component ranked the highest, and this in accordance with previous study. And we also found that there is significant difference between SpO2 and PEFR before and after nebulizer treatment, and this is also supported by literatures. And we proved that higher income provide a better quality of life. And this is in its concordance with the study done by Akia et al. 2007, because higher income can provide a better accommodation, thus asthmatic patients can have a better lifestyle. And lastly, there is no association between frequency of hospitalization with quality of life, because asthmatic patients capable to cope with their illness, thus they still can have a favorable quality of life. And by the way, prompt treatment in the casualty or in the clinics can lead to this indifference between quality of life and frequency of hospitalization. And lastly, I would like to conclude that asthmatic patients in UKMMC possess moderate quality of life, lung function improved after nebulizer administration in casualty, and respondents with income more than 4,000 ringgit per month had a better quality of life compared to the less than that. And lastly, quality of life did not determine the frequency of hospitalization due to asthmatic attack. These are the list of references, and with that, we would like to show our gratitude to those who involved in this study. Thank you. Any questions from the floor?
Yeah, I have 2 questions.
Yes.
Number 1, the result of PEFR are related to the instruction given to the patient. So
Yes.
how do you instruct the patient to perform PEFR? That question number 1.
Okay.
Number 2, those who have acute asthma, severe one, normally they can't talk, they cannot speak. How you handle these patients?
For the answer, thank you for the very good question, Prof. Okay. For the answer, question number 1, based on what we learned in this medical faculty for 5 years, that's what we applied in this study, in which we need to give a command for them, a correct command, so that they can do the PEFR very well using peak flow meter. And the second one is, the second question, I'm sorry.
Patient with acute asthma,
Okay.
normally they can't talk well, they cannot follow instruction. So how do you handle these patients to perform PEFR?
Okay, thank you.
Have any patient in this group?
Sorry?
Do you have any patient with acute asthma? With
Yes.
severe asthma?
Yes, acute asthma, but in our exclusion criteria, we exclude those presented with severe condition, then we will definitely exclude them from the study because they cannot talk. So any more questions from the floor? With that, thank you.
Thank you, Ms. Nurukia. Now, there's another interesting study about skin aging. This group had been studying on the effects of Chlorella vulgaris on the expression of genes encoded for collagen and matrix metalloproteinases, which are involved in skin aging. So, does this microalgae affect skin aging? Well, let's find out from the next presenter, Ms. Lok Choi Yin of Group 7, Department of Biochemistry.
A very good morning to the panel judges, professors, doctors, and my fellow friends. I'm representative from Group 7, and today I'm going to present on our group topic. Does Chlorella vulgaris modulate the expressions of collagen and matrix metalloproteinases genes in skin aging? For introduction, cellular senescence is also known as aging in layman term. It occurs because there is an imbalance between the oxidation and antioxidant defense system in the human body. Being the largest and the outermost organ, and also contain a lot of biological substances, skin therefore is most susceptible to oxidative damage. And since actual senescence process takes a long time, we choose to use stress-induced premature senescence model in our study. It is actually a sustained effect of subcytotoxic stress on proliferative cell types. And in our study, we choose to use hydrogen peroxide because it has been proven to induce senescent morphological changes, which is similar to the replicated senescence seen in human cells. And there are 6 different genes in our study, which are gene collagen 134 genes involved in collagen synthesis, and MMP 123 genes, which are involved in collagen degradation. 3 parameters are being used to measure the effect of skin aging in our study. First is the senescence-associated beta-galactosidase, which is an enzyme expressed by the senescent cell. Second is the expressions of genes and also expressions of protein involved in collagen synthesis and degradation. And why Chlorella vulgaris is our choice of antioxidant? There has been extensive studies on other well-known antioxidants, for example, vitamin C, vitamin E, honey, and their antioxidant effect have been widely recognized. However, comparatively, there is less study on the antioxidant effect of Chlorella vulgaris. And based on the field researches done before, seaweed has been proven to contain antioxidant and also anti-tumor effects. The objective of our study is to determine the effect of seaweed on the expressions of collagen and matrix metalloproteinases genes in skin aging. We would like to determine the baseline changes on the expressions of genes involved in skin aging, and second, to determine the effect of seaweed on the expressions of collagen and MMP genes, and third, to determine the effect of seaweed on the expressions of proteins involved in skin aging. Lastly, we would like to determine the effect of seaweed on the expressions of SA beta-galactosidase. In our research, we hypothesized that in skin aging, the expressions of collagen gene will decrease, while the expressions of MMP gene will increase. The expressions of core genes will increase, while the expressions of MMP genes will decrease with prolonged treatment by seaweed. And third, the expressions of core 1 and 3 proteins will increase, while the MMP1 protein expression will decrease with prolonged treatment by seaweed. Lastly, the percentage of cell that is positive for SA-beta-galactosidase will decrease with prolonged treatment by CV. This is our experimental design. We are using fibroblasts from the circumcision skin of 9 to 12-year-old boy, and we subculture them. The cell culture are divided into 3 main groups. The first group is the control group. Second group is treated with hydrogen peroxide, starting at passage 6. And the third group is treated with CV at passage 4, and later hydrogen peroxide is added at passage 6. After completing the treatment, we conducted a series of tests, which were SA-beta-galactosidase assay, total MMP1 assay and Western blot to determine the protein expression, and lastly is the real-time reverse transcriptase PCR to determine the gene expression. These are the primer sequences we are using for each gene, and GAPDH is our housekeeping genes. Now look at our result. First, we look at the morphological changes in the cells. For the control group, the young fibroblasts are spindle-shaped, while for the group treated with hydrogen peroxide and also with prolonged treatment of CV, they exhibit senescent morphological changes. For example, the cells are flattened, elongated, and they are also stained blue for the SA-beta-galactosidase. Looking at this graph, we can see that with prolonged treatment with CV and also hydrogen peroxide treatment, both of them did increase the expressions of SA-beta-galactosidase if compared to the control group. And this is the Bell curve chart. From here, we can see that there is a single and narrow peak for each gene, indicating that the primer sequences we are using are specific. And we can see there are bands present for every gene on agarose gel, also signifying the specificity of our primer sequences. Now let's look at the 3 collagen genes expression. First, we would like to see the baseline expression of these 3 genes. If we compare among the control group of these 3 genes, obviously, COL1 gene has the highest expression compared to the other 2. This is because collagen 1 is the most abundant collagen in the skin, while collagen 3 mainly forms the reticular layer in the dermis, and collagen 4 forms the basement membrane. And looking alone at the COL1 gene expression, we can see that by treatment with hydrogen peroxide and also prolonged treatment with CV, both down-regulated the expressions of COL1 genes. However, looking at the COL3 gene expression, the prolonged treatment with CV upregulated COL3 gene expression compared to the group treated with hydrogen peroxide. But for the COL4 gene expression, both hydrogen peroxide and prolonged treatment with CV did not have any effect on its expressions. This is the 3 MMP genes expressions. From here, we can see that prolonged treatment with CV upregulated MMP1 gene expression compared to the other 2 groups. But for MMP2 and MMP3 gene expressions, both did not have any effect on its expressions. This is the Western blot analysis of collagen 1 and 3 proteins. From here, we can see there are beta-actin bands present for these 3 groups. However, it failed to show further presence of any band due to the low concentration of proteins in the sample. This is the MMP1 protein assay in our MMP1 protein assay, and we can see that treatment with hydrogen peroxide and also prolonged treatment with CV did not have any effect on MMP1 protein expression compared to the control group. For the discussions, previous study reported that after hydrogen peroxide treatment, the expression of SA-beta-galactosidase was increased and the DNA synthesis was down-regulated. In our study, prolonged treatment with CV down-regulated COL1 gene expression, but up-regulated COL3 and MMP1 gene expressions. Based on a study done by Chin-Chen and Bruce in 1994, hydrogen peroxide induced senescent morphological changes and irreversible arrest in cell replicative capacity in human fibroblasts. And in their study, they found that the effect exerted by hydrogen peroxide are cumulative and irreversible. And the cell could not enter cell cycle again even with mitogen stimulation. This might explain why CV could not reverse the effect of hydrogen peroxide in our study. And the MMP1 gene upregulation in our study is consistent with the result by Peter Brandenson, in which he found that hydrogen peroxide increases the steady-state mRNA level of MMP1 in human fibroblasts. And lastly, according to a study by MD Saad et al., he found that the beneficial effects of CV had not been fully recognized. In his study, CV induced apoptosis in order to maintain normal cell homeostasis. In addition, it also inhibits growth in cells which could not be repaired anymore. For conclusion, in skin aging, collagen 1 and 3 genes were downregulated, while MMP1 gene was upregulated. Seaweed thus modulate the expressions of collagen and MMP genes in skin aging by downregulating COL1 gene and upregulating COL3 and MMP1 genes. From here, I would like to thank everyone who had helped us in our study. Thank you.
Can you put your conclusion in a more simple and clinical manner? What's the clinical implications?
Clinical implications. We found that after the treatment of seaweed, it only upregulated expressions of COL3 and MMP1 genes. But for the COL1 gene, it downregulated it instead.
Any clinical implication of that?
My group member, can you help me? Maybe the clinical implication is that actually seaweed did not really have any effect on the COL1 gene expression, which is the most abundant collagen in the skin, which means that it really doesn't have much effect on anti-aging effect, anti-aging effects. Any questions?
Okay, while doing the study, during your literature review, do you find any contraindication for the CV? Can anyone take CV? Thank you.
We did not really find any research journals on the CV because very few researchers had been conducted on the effect of CV. That's why we did not have much journals to compare with the results. Thank you.
Okay. Thank you, Ms. Lok. Due to shortage of time, perhaps we shall continue the next presentation. The next group, please get ready.
Stop.
Kami sedang berada di Hospital Surabaya atau Rumah Sakit Surabaya.
Doktor apa ni? Doktor?
Saya bukan doktor.
Rumah Sakit RSUD?
Radiculopathy, myelopathy, brachial plexus injury, PID semua pun ada.
Previous purposes relapse. Sekali.
Maknya lagi di telepon bapaknya. Tak tahu belum.
Bagiku melupakanmu.
Siapa tu?
Waktu seumur hidup.